All right, welcome everybody to our first dysphagia lecture. Janet and I are excited to work with you this summer. I, of course, am Kristen Palmer, KP, and we love dysphagia. We love everything swallowing, and we're so excited to have you here with us. Buckle up because I know this first class is a kind of a lot to take in, but it is review of anatomy and physiology. There's lots of muscles and cranial nerves that we will cover, but just take a deep breath and we will get there. Because all the cranial nerves and all the muscles haven't changed. They're the same ones that you've learned in every class before us. As we go through this semester, you're going to learn about dysphagia. That is our medical word for any difficulty that people have with swallowing. It could be discomfort or pain or difficulty swallowing. Um, we're looking at the swallowing process from when food starts in the mouth as it proceeds through the throat, the esophagus, and all the way to the stomach. As you go through the semester, you're going to figure out and learn all these words which may look foreign to you right now will become second nature. Fees, dysphagia, epiglottis, bolus, modified barium swallow study, pneumonia, aspiration, penetration, oropharynx, epiglottis. You're going to get all these words. We study dysphagia, the difficulty swallowing, because complaints are common, especially as people age. Approximately 7 to 10% of adults older than 50 have some type of dysphagia, although this number might be artificially low because many patients who have difficulty swallowing may never seek medical care. Up to 25% of hospitalized patients and 30 to 40% of patients in nursing homes can experience swallowing difficulty. Let's take a look at some of the causes of dysphagia. They can be neurological or mechanical. Neurological causes might include stroke, brain tumor, brain injury, Parkinson's disease, different muscular dystrophies, ALS, multiple sclerosis, myasthenia gravis, dementia. Mechanical causes could include changes after surgery. Maybe they had a spinal surgery and there's hardware in place. Maybe there's a trach that was placed to help with breathing. Maybe there's a vocal cord paralysis, or little pockets in your throat that shouldn't be there, like a Zenker's diverticulum. Or the person could have had head and neck surgery, head and neck cancer and surgery and radiation. So those are some different mechanical causes. We're going to take two looks at swallowing today with anatomy and physiology. We're going to start with an overview of just the broad stages of dysphagia and swallowing, and then we're going to dig deeper into all the muscles that are involved. In class, we will do a cookie lab. Well, I call it a cookie lab. You should bring any snack. Bring something that you have to chew and something that you have to drink, and we will talk about that in class. Let's look at the stages, the phases of swallowing. For textbook learning, we could divide it into 4 different categories: the oral preparatory stage, where you're chewing the food, the oral stage, the pharyngeal stage, and the esophageal stage, which each corresponds with what part of the body the bolus is in. But as you'll see in reality and in practice, the swallowing mechanism is really a synergistic event with each phase affecting the others. So a difficulty with the oral stage could impact a later stage, whereas vice versa is also true. Difficulty in the esophageal stage may affect other stages. Swallowing is a complex neuromuscular phenomenon comprised of both voluntary and involuntary sensory and motor events that are necessary for the bolus to pass safely from the stomach to the mouth. It involves approximately 30 facial muscles and 8 cranial nerves. Looking at the oral stage, first you have the preparation, which takes place when you're chewing and preparing the food. This could last anywhere from 5 to 10 seconds. But then once you initiate the oral stage and transfer, that transfer is very quick, about 1 second. The bolus formation is accomplished by the actions of the lips, the tongue, the mandible, the palate, and the cheeks, all those muscles working together, along with the salivary glands that add some moisture and saliva to help manipulate the bolus into an appropriate size and consistency for swallowing. If you have an oral stage dysphagia or problems in the oral stage, what might it look like? Well, think about all those things that could happen in the oral stage. Maybe you have food or liquid spilling out of the mouth. Maybe you're drooling. Maybe it takes you a very long time to chew because you don't have good dentition. Maybe you're holding or pocketing food in your cheeks because you're not aware that it's there. Maybe you have decreased sensation and you don't know the bolus is there, so you don't swallow it. A few other causes could be structural changes, like this baby that has a cleft palate, or this person on the right who has had part of their tongue resected, probably from a cancer. Looking at some pharyngeal stage problems. Um, People might have trouble starting a swallow, that swallow initiation. Their swallow could be delayed. There might be residue in the pharynx. So after they swallow, there could be food or drink left in the little pockets in their throat, or there could be nasal regurgitation, food or liquid coming up into the nasal cavity. Two other big words that we use when talking about the pharyngeal stage are penetration. That's when we talk about foods or liquids that start to enter the laryngeal vestibule, that start to go the wrong way, but it's still above the level of the vocal folds. And the other word we use is aspiration, and that would be passage of food or liquid into the airway below the vocal cords. Typically, we would cough and choke if that happens, but not all of our patients do because they don't all have good sensation. Looking at some pharyngeal stage problems, they might be structural. In this case, we have a little pocket in the throat that should not be there, like a diverticulum. This patient has some bony outgrowths called osteophytes that could impact the passage of the bolus. And this person has had some surgery where they put some hardware in, and that could impact the flow of the bolus. The esophageal stage. In a normal esophageal stage, it will last about 8 to 20 seconds, and peristalsis is the main action that moves the bolus through the esophagus, along with some assistance from gravity. The esophageal phase starts at the upper esophageal sphincter through the esophagus to the lower esophageal sphincter and the stomach. Different problems with the esophageal stage could include people complaining of heartburn, fullness in the chest, saying that food feels stuck. There could be esophagitis, which might be from reflux, and there could be structural changes like webs or rings, dysmotility, or other systemic causes. So looking at a couple pictures, we see on the left-hand side, we see a web or a ring that could impact how the bolus flows through the esophagus. We could see a stricture or a narrowing that impacts how the food travels, or we could see something like achalasia, described as like a bird's beak, which is also another narrowing. For all these cases, you would have your GI doctor involved in these cases. All right, now we're going to dig in and take a closer look. This is when we're going to start talking about muscles, so don't panic. We got this. We are going to look at all three stages of swallowing and the structures and muscles that are involved. So as I said, swallowing takes over 30 muscles and 6 cranial nerves. Maybe you could make a case for 7 or 8 of them also. All right, as we dive in, we're going to talk about the oral cavity first and all the borders and boundaries of the oral cavity. So we'll be going over the lips, teeth, cheeks, hard palate, soft palate, uvula, mandible, floor of mouth, tongue, plus the salivary glands, which are important for us also. The lips are formed by the orbicularis oris, which is a circular muscle originating from the maxilla. The teeth, there are 24 deciduous or baby teeth and 32 permanent teeth in most people. The cheeks are formed by the buccinator muscle. There are little pockets in your mouth. We have the anterior sulcus, which is right behind your lower lip, and the lateral sulci, which are on the sides. You can kind of put your tongue in that groove. Looking at the superior border of the oral cavity, that is the top of your mouth. We have the roof of the mouth, which is formed by the hard palate or the maxilla bone. The soft palate is formed by the palatoglossus muscle, which can help to pull down the soft palate against the back of the tongue. If you make the sound like K or G, like k, then you can feel the back of your tongue touching the soft palate. Velopharyngeal closure is also accompanied by movement of the palatoglossus, palatopharyngeus, which is the posterior faucial arch, and we'll get more into that again too. The inferior border, that is the bottom of your mouth, the floor of your mouth, is formed by the mandible, that bone, as well as many muscles that form the floor of the mouth, including the mylohyoid, geniohyoid, the anterior belly of the digastric. Also along the floor of the mouth is your tongue, which is composed of muscles that run in different directions that help you to have good, clear speech and articulation, as well as swallowing. The salivary glands are also important. They produce different types of saliva. We have one type of saliva that is a little bit thicker and some that are a little thinner. Some of the salivary glands are the parotids, the submandibular, and the sublingual salivary glands. All right, so looking at lip closure. Like I mentioned, the orbicularis oris is the main muscle. It's a circular muscle that originates from the maxilla and mandible, and it helps with lip closure. So think how this is important. If you're using a spoon and you try to take the bolus off the spoon, you use your lips to help you do that. If you're using a straw, if you're taking a sip from a cup, if you're chewing food and your mom says, keep your mouth shut, that is your lips working there. Also important are the buccinator muscle, which helps to tense the cheeks. That's important for maybe drinking through a straw because it helps you pull the bolus into your mouth. The intrinsic tongue muscles. These 4 muscles are also innervated by the hypoglossal cranial nerve number 12. They help to keep the shape and tone of the tongue. These muscles are named for the direction in which the fibers travel. So the superior longitudinal muscle runs along the top of the tongue, long ways. The inferior longitudinal runs along the bottom of the tongue, Both of those together work to move the tongue tip up and down. The transverse muscle moves across the tongue. We can see here. Um, and it helps to narrow and elongate the tongue. And the verticalis runs vertically up and down along the tongue. And those muscles, when they contract, help to flatten and broaden the tongue. These four muscles together work to maintain the shape of the tongue. So you can think about if you have food in your mouth or a liquid in your mouth and you need to control it, that's what these muscles will help to do. They're also important as a pressure generator. This is one of our pressure generators of swallow. As you initiate the swallow, the tongue tip can press against the roof of your mouth and applies pressure to the bolus to help propel it the rest of the way through the swallow system. Now we have the extrinsic tongue muscles. There are four of them. They are also all innervated by the hypoglossal cranial nerve number 12. They help to aid in the positioning of the tongue in relation to the oral cavity and the other pharyngeal structures. The genioglossus is important for when you want to stick your tongue out. The styloglossus can help elevate the sides of the tongue to help you make that little bowl of your tongue for swallowing, for holding the food safely. The hyoglossus can retract the tongue, and the paladoglossus forms the anterior facial arch, which helps to elevate the posterior tongue, and this helps to prevent the bolus from spilling into your pharynx too soon before you're ready to swallow. If somebody has problems with these muscles, maybe from weakness, from a stroke, on one side of the body, you might see difficulty with tongue control. You could see food or liquid spilling into the lateral sulcuses in the mouth or the floor of the mouth or posteriorly into the pharynx. Okay, now we're going to look at the muscles of mastication. These are innervated by our friend the trigeminal cranial nerve number 5, muscles of mastication. These muscles help to chew and prepare the food before you swallow it. There are 4 muscles. 3 of them help to elevate or close the mouth and jaw, and 1 depresses or opens, lowers the jaw. So the masseter is a very strong muscle. You can feel it if you put your fingers right by your temporal mandibular joint, like right by your ears, and bite up and down. You can palpate or feel that strong contraction of the masseter muscle. The temporalis is a fan-shaped muscle. That's also important for elevating the mandible and closing the mouth. And you can also palpate that near the temple. The medial pterygoid helps to move the jaw from side to side, as well as helping with mouth closing. And then the lateral pterygoid is our only one that helps to lower, depress, or open the jaw. So lateral, lower. There's your memory strategy. Lateral starts with an L. Pterygoid lowers the jaw. If you have problems with these muscles, you could imagine that you would have difficulty chewing or masticating the food. For safe swallowing, we really need to have the particle size after chewing. The particles of the bolus should be about 4 millimeters in size. This will corresponds with, like, if you look at a fork, the little pieces of the bolus should fit between the prongs of a fork. That's about 4 millimeters. And that's about the size that food needs to be masticated to be safely swallowed. Oh, and I added this page in here with some pictures. If you want to color, you can color those those muscles of mastication. All right, so we also have sensory input. You know, swallowing is not just a motor response. There's also sensory input. So there's different mechanoreceptors, thermoreceptors. You're getting input about the temperature, the taste, the position of the bolus, and all of this is coordinated with the brain. The sensory input triggers the pharyngeal swallow and modulates a sequential motor activity of muscles that then transports the bolus through the pharynx. All right, so we're going to review the oral stage. The different components of the oral stage are that we're going to put the food and liquid into the oral cavity. We're going to make sure that it stays there and doesn't, fall out of our mouth or into the little sulci on the side. We're going to use all those muscles to chew and masticate to make sure it's all mixed well. The saliva is going to help us. We use our teeth and our jaw and our tongue movement to help chew the food too. And then we form the bolus into a nice ball that sits on the tongue and gets ready for us to swallow it. And that is the oral stage. So think about those muscles. Can you name 10 of those muscles that are involved in the oral cavity? Here's a lovely picture that maybe you'll see again that you should be able to label some of these muscles. Oh, I thought I had the answers, but they're not there. Oh well, stay tuned for more answers. The pharyngeal stage. So now we will dig into the pharyngeal stage. So most of the oral stage is voluntary because you're aware of chewing the bolus and getting ready. But as we get to the pharyngeal phase, there's some involuntary components. Respiration and swallowing are highly coordinated since, as I mentioned, you have to stop breathing for that moment of the swallow. There is a central control of the pharyngeal swallow is efficient and automatic mechanism, so therefore it is involuntary. The complex sequence of events responsible for the pharyngeal swallow is known as the central pattern generator, and that is housed in the brainstem, specifically the medulla. You should remember that always. The medulla is the center in the brain for swallowing. The swallowing reflex is called the central pattern generator in the medulla. All right, so now we're going to go through all the different parts of the pharyngeal phase. So just for background, we talk about, we define the location as the nasopharynx, which will be anything like behind the nose. The oropharynx is the structures around the area of the mouth or oral cavity, and the hypopharynx is the lowest portion of the pharynx. We're going to go through and talk about different landmarks, which will include the base of tongue, which is that part of the tongue that you cannot see because it's in the pharynx, the epiglottis, the laryngeal structures, which are the vocal folds, the false vocal folds, the arytenoids, now it's sounding like voice class, the posterior pharyngeal wall, and the piriform sinuses, which are little pockets that are formed in our throat. Okay, looking at the pharyngeal phase components, we're going to go through each of these in a little more detail, but this is your preview. As I mentioned before, sensory receptors in the oropharynx and the deep purpose, sorry, there's banging upstairs. These are all controlled in the brainstem to initiate the pharyngeal swallow. In young normals, the pharyngeal swallow is often triggered as the head of the bolus passes the anterior facial arches towards the mouth, but as we get older, it is still considered normal for the swallow to be triggered as the bolus passes even a little lower and into the pharynx. All right, velopharyngeal closer. When we swallow, we do not want food or liquid going into our nose. So we must make sure that we have good muscle contraction of those muscles that help to elevate the soft palate so that food and liquid don't go into our nose. And these are the muscles that do that. the levator veli palatini, the palatoglossus, and the styloglossus. So we need good pharyngeal closure so that food and drinks do not go in our nose. This is another part of the pressure generating system. So the first part of the pressure generating system was when your tongue pushes up on the roof of your mouth to initiate the swallow. And here's another pressure generator, is the good closure at the level of the velopharyngeus, because that helps to generate pressure to propel the bolus onward. Now we're going to look at suprahyoid and infrahyoid muscles. The suprahyoid muscles in general are a group of 4 muscles that are located superiorly or above the hyoid bone, and they all act to elevate the hyoid bone. This is a Jeopardy question. The hyoid bone is the only bone in the body that is not attached to another bone. It is only supported by muscles. So I believe that was on Jeopardy, and you can remember that. So the suprahyoid muscles arise from the tongue and mandible and skull, and they insert into the hyoid bone. They act together to elevate the hyoid bone, which influences the movements of the floor of the mouth and the tongue. To remember the suprahyoid muscles, we have the memory strategy, dig my style, it's genius. So the digastric, the mylohyoid, the stylohyoid, and the geniohyoid. Dig my style, it's genius. Those are the suprahyoid muscles that help to elevate the hyoid, which is important during swallowing. The infrahyoid muscles generally arise from the sternum and the thyroid cartilage of the larynx, and they insert into the hyoid. These muscles partially resist elevation of the hyoid during swallowing. The memory strategy for them is TOSS, T-O-S-S, thyrohyoid, omohyoid, sternohyoid, and sternothyroid. Important in swallowing is this forward movement of the hyoid. So we have anterior hyolaryngeal elevation. We need the larynx to move both up and forward as you swallow. In research, they studied young men. So, take that for what it's worth. But in those typical young men, the hyoid elevates about 2 centimeters during the swallow. This is something we attempt to palpate with laryngeal elevation at the bedside. We have learned that you cannot judge a good swallow or adequate laryngeal elevation just by feeling their swallow, but you can feel if something's happening. You can feel if they swallow. You just might not be able to say that it is, great or excellent. All right, so these are muscles that are important to contributing to the anterior hyolaryngeal elevation. The suprahyoid muscles, like we just talked about, are important in that role. Here is a picture of the suprahyoid muscles and the infrahyoid muscles. And this time I did remember to give you the answers. Enjoy. Okay, so now our bolus, our food is traveling through our throat, through our pharynx, and we have to make sure it goes the right way and does not head towards our vocal folds or our airway. So in order to not aspirate, we need to make sure we have good protection of our airway. There are 4 layers of protection for our airway. First, we need the true vocal folds to close. They're going to adduct and close. Next, the false vocal folds, which are slightly superior to the true vocal folds, will also squeeze shut. The arytenoids will come together and tilt towards the base of the epiglottis, and finally the epiglottis will fold over or invert to help direct the bolus into the esophagus and not into your trachea. If anyone has a problem with laryngeal vestibule closure, you may notice that they are coughing or choking or throat clearing or having any kinds of symptoms of aspiration. Here's another pressure generator, the tongue-based movement. So we need the base of the tongue. Remember, that is the part of the tongue that you can't see in the mouth. It's in the throat. We need good tongue-based movement to get close to the posterior pharyngeal wall. So they squeeze together. They should make really good contact to help squeeze and push the bolus further down. If the tongue base is weak and doesn't have good retraction, you might see residue or food left in a little pocket in the throat. This little pocket is called the vallecula. You must always remember that. The vallecula is formed here between the base of the tongue and the epiglottis. And it's probably there because these muscles were weak when they went to swallow. The squeeze and contraction was not enough, and so a little bit of the food was left over. Oh, we're having so much fun. Next up, we have my indie band, the Pharyngeal Constrictors. There are 3 pharyngeal constrictors. The pharyngeal stripping wave is completed by the muscles, the superior, medial, and inferior pharyngeal constrictors. They help to shorten and elevate the pharynx to help move that bolus through. The superior pharyngeal constrictor is actually the weakest of all of them, and the strongest is the inferior pharyngeal constrictor, which you can see down here. The inferior constrictor attaches to the sides of the thyroid cartilage and helps to form some pockets in our throat, which we call the piriform sinuses. We'll hear more about them later. All right, so in order for the bolus to move safely through the pharyngoesophageal segment, we need the cricopharynx to relax, the good hyolaryngeal elevation, and pressure generated on the bolus. So reviewing the pharyngeal stages. For the bolus to travel safely and efficiently through the pharynx, we need to have the velopharynx closed so it's not going in our nose. We need the pharynx to shorten and expand. We need the airway to be protected. The larynx will elevate, and then the upper esophageal sphincter will relax and open. Here's another picture for your diagramming fun and more answers. There's the answers. All right, so that was a whole bunch of pharyngeal muscles. Think about the suprahyoids and the infrahyoids and the pharyngeal constrictors. Can you name those muscles? Now we'll take a quick peek at the esophagus. The esophagus is a muscular tube that is collapsed at rest. It is 23 to 25 centimeters long, and there is a valve or sphincter at each end. The esophagus is composed of 2 layers of muscle, an inner circular muscle and an outer longitudinal muscle. So the inner circular muscle can help with that squeezing peristaltic motion, and the outer longitudinal muscle is like an up and down direction of the fibers. The upper 1/3 of the esophagus is striated muscle, and the lower 2/3 is smooth muscle. The esophageal phase is also involuntary because we don't really have control of the esophageal phase when you swallow. Like I mentioned before, the bolus travels through primarily from the peristaltic wave motion, but also with some help from gravity. Oh, and now we have a practice question, which you can look at and we can talk about in class. And another practice question. And another practice question. All right, so I know that was lots and lots of information, but we're going to go over it again in class and give some examples and some different case studies and talk about how you can make this easier to learn. Thank you all. I will see you on Tuesday.